This conference will now be recorded.
A very good afternoon to all of you. So, am I audible or not? Yes?
Yes, ma'am.
Yes, ma'am.
Okay, we'll start. So, you're all 7th semester students, no? So, today we are going to discuss about post-menopausal bleeding. So, post-menopausal bleeding. So, first, before going to post-menopausal bleeding, you should know what is menopause. So, menopause is nothing but permanent cessation of normal menstruation. So, the patient tells that she's not been having menses. So for how much period? So it is for more than 12 months. It is for about 1 year. If the woman stops menstruating, then it is called as menopause. So the mean age of menopause is 51. Normal range is about 48, not is not 45 to 56 years. It is 48 to 52. Okay, 48 to 52 years is a normal age of menopause and the mean age is about 51. Suppose, now I'm going to ask you a question. Suppose if the patient was not having menses for 6 months. After 6 months, she tell you that she's having spotting. You want to evaluate her or you will tell her there is no problem. You can wait for another 6 months. So you have to evaluate her. Even the definition is the menopause is cessation of menses for about 1 year. But if the patient complains of bleeding after 6 months of amenorrhea, she has to get investigated. Why? Because you have to rule out carcinomas in menopausal women. So post-menopausal bleeding. So it is bleeding from the genital tract occurring for at least 1 year following the cessation of spontaneous menstruation. So after spontaneous cessation of spontaneous menstruation, if there is bleeding from the genital tract, after 1 year, it is called post-menopausal bleeding. It is a serious symptom which may indicate the presence of malignant disease in the genital tract. So every woman who complains of postmenopausal bleeding, you have to assume to having a carcinoma until and otherwise proved. So you have to investigate her. So investigation. So you have to evaluate the cause of bleeding. So there are different causes of postmenopausal bleeding, which I will be discussing, and you have to exclude all the causes. First of all, you have to exclude carcinoma, and then you have to treat the patient. So what are the different causes of postmenopausal bleeding? So first are the local causes. So local causes, first we'll start on the uterus. So uterus, the causes can be an endometrial, endometrial hyperplasia, endometritis, endometrial polyps, endometrial carcinomas, leiomyosarcoma of uterus. So senile endometritis also can be the cause. Next, coming to the next organ is cervix. So in cervix, when the patient is having cervical polyp or any history of cervical trauma or cervicitis, infection of the cervix, or in case of cervical carcinoma, the patient can have postmenopausal bleeding. Coming to the next organ is vagina. So any saline atrophic vaginitis, vaginal trauma, any foreign bodies, especially pessaries. So where do you use pessaries? In case of prolapse, treatment of prolapse, you use a forgotten pessary as a cause for bleeding, and vaginal inflammation, vaginal polyps. Last is vaginal carcinoma. So you have to exclude all these things. Next, coming to the next is vulva. So any vulval trauma, vulval dystrophies, vulval carcinomas. Other also you have to exclude like fallopian tube carcinoma, secondary tumors. So in the ovary, breast, colorectal carcinoma, urethral current. So in ovary, what are the tumors in the ovary that can cause postmenopausal bleeding? There are Brenner's tumor, okay, granulosa and theca cell tumors of the ovary. They all can be the cause for postmenopausal bleeding. Okay, so why in Brenner's tumor or in case of granulosa theca cell tumor they cause bleeding? Because these tumors, what they secrete? Estrogen. Coming to the systemic causes. So first we have completed the local causes. Now coming to the systemic causes. So systemic causes are any bleeding disorders like thrombocytopenia, leukemia, pancytopenia, hormone replacement therapy. So where do you use HRT? Hormone replacement in case of menopausal woman, right? So in case, suppose if she's having menopausal symptoms, what we do is we put the patient on HRT. HRT is nothing but hormone replacement therapy. So in HRT, there is estrogen. So in postmenopausal bleeding, and the menopausal woman, when she is on HRT, she can have postmenopausal bleeding. So you have to ask proper history is very important. Suppose if she is on HRT and she is having bleeding, then there is no need to evaluate because that is the cause of bleeding, right? And estrogen producing tumors, that is in ovary, in the, okay, these are mainly the ovarian tumors, fallopian tumors, they produce estrogen producing tumors. And peripheral conversion of androstenedione. So androstenedione is peripherally converted into estrone by the enzyme aromatase. So when there is estrogen conversion, then there is postmenopausal bleeding, right? Next. Then these are the causes. Now, what is the most common etiologies? So etiology is nothing but when you do evaluate the patient of postmenopausal bleeding. So these are the common causes that lead to postmenopausal bleeding. So after evaluation, it is after investigations. So most common cause is atrophic vaginitis. So atrophic vaginitis is also called as senile vaginitis. So atrophic vaginitis is also called as senile vaginitis. It is about 60 to 80% of the cases of senile vaginitis are the cause. Next is estrogen therapy in case of HRT. And because of endometrial cervical polyps, about 12%. Endometrial hyperplasia, they constitute about 5 to 10%. And about 10 to 15% cases are carcinomas. Okay. It can be endometrial, it can be cervical, it can be ovarian. About 15% they constitute carcinomas. So coming to the most common is atrophic vaginitis. What is atrophic vaginitis? It is nothing but is also called as senile vaginitis. So this is a per speculum examination of the vagina. So this is all you're looking at a per speculum examination of the vagina. So you can see the, okay, these are atrophic. So you can see the vagina is pale and it is atrophic and it is very thin, right? Why? Because in a postmenopausal woman, the vagina is atrophic thin. Why it is thin in postmenopausal woman? Why? As everybody knows that in menopause, the ovary has no follicles, right? From the follicles only, if follicles are present, the estrogen is secreted from the follicles. So you have to have an idea of from where the estrogen is produced in normal women, normal females. So what is a master endocrine organ? So master of all the endocrine organ is your hypothalamus. So hypothalamus will have an arcuate nucleus, right? So arcuate nucleus will secrete what? GnRH, gonadotropin releasing hormone, right? It doesn't have an, it does not have an inhibitory hormone. It has only releasing hormone. So GnRH, gonadotropin releasing hormone. So it is secreted from the hypothalamus. So this acts on where? Acts on the anterior. So pituitary will have an anterior and a posterior pituitary. So when this hormone, releasing hormone will act on anterior pituitary, there is secretion of FSH and LH. So when there is secretion of FSH, LH, what happens? This FSH, LH will go and these gonadotrophins, FSH and LH will go and act where? On the ovary. So normal ovary, it is not menopausal, normal, in normal ovary it acts and it secretes hormones. So from the ovary, what are the hormones secreted? Estrogen, progesterone, androgens and inhibin. So these are the hormones which are secreted by the ovary when there are follicles, right? So the estrogen which is secreted from the ovary will act on the target organ. So what is the target organ here in the female? It is nothing but the uterus, vagina, everything. So it is from the vagina, it is from the, it acts on the target organs. Okay. So when the estrogen acts on the target organs, what happens? Endometrium is thickened, the vagina is healthy, so it improves the vaginal epithelium. So when there is vaginal epithelium improvement, what happens? There is from the vagina, because of estrogen, there is glycogen. So when the glycogen is there, what happens? The glycogen will, in response to lactobacillus in the vagina, it releases lactic acid. So increase of glycogen content. So glycogen is very important. When there is more amount of estrogen, there is growth of the vaginal epithelium, endometrial epithelium. So when the vaginal epithelium grows, what happens? The glycogen is increased. When the glycogen content is increased, what happens? So when the glycogen content is increased, what happens? So when the glycogen content is increased, what happens? There is action by the lactobacillus, which will form the lactic acid, which will decrease the pH, and it is responsible for the defense mechanism in the normal female. So what happens here in atrophic vaginitis? Because she is a post-menopausal woman, the ovaries will not have any follicles, zero follicles. There is no, even FSH, LH is there. There is no action on the ovary because of the no follicles, no estrogen secreted. When estrogen is not there, what happens? The vaginal epithelium becomes thin, and it is very thin, and it is very easily will have trauma. When there is trauma, there is breeze, there is infections. Okay, it can cause postmenopausal breeze. So that is the cause for postmenopausal bleeding in case of atrophic vaginitis. So what is the treatment in women on combined cyclical HRT? Bleeding in the progesterone free period is normal. So unscheduled bleeding refers to bleeding at other times. This is abnormal and should always be investigated. So in women with HRT, they can be bleeding in progesterone free period interval. So in case of senile vaginitis or atrophic vaginitis, what is the treatment? You can see here, this is a vaginal cream. It is a local estrogen cream. So you can apply this local estrogen cream and ask her to apply 3 days in a week and one free week, you can tell her. And about 1/3 of this vaginal cream is absorbed into systemic circulation. Or she can use oral conjugated equine estrogen, that is Primarin. She can use conjugated equine estrogen. She can use, and there will be when what happens when the estrogen is used. So you know that. So when the estrogen is given to the postmenopausal woman, in case of atrophic vaginitis, there is improvement in the vaginal epithelium, there is increase of the glycogen content, and there is action of the lactobacillus, and there is release of lactic acid, which will decrease the vaginal pH, and everything it is restored. So the patient will be relieved of the symptoms. Okay. And other causes I told you polyps. So you can see here in the diagram, you can see it is a polyp. So it is fundal uterus, a polyp. It's a pedunculated polyp. Okay, this is a sessile polyp, and here also you can see the polyps. So these can have post-menopausal bleeding. So this is, you can see it is a polyp. It is a hysteroscope. This is a hysteroscopic. When you do a hysteroscopy, direct visualization of the uterus, you can see an endometrial polyp is there. So this is a polyp. This is a feeding vessel. So single feeding vessel, the diagnostic of a polyp, right? This is a hysteroscopy. That is through a scope, you just look into the uterus, what is there. Next, coming to the other common causes, endometrial hyperplasia. So endometrial hyperplasia is nothing but abnormal proliferation of endometrium. So there is endometrium has what? Stroma and glands. Na? So endometrium is comprised of glands and stroma. So there's proliferation of these elements. That is most common, that is glands are proliferated in case of endometrial hyperplasia, and the cause of it is 5 to 10% cases of postmenopausal bleeding. It occurs due to excessive estrogen stimulation. So when there is excess of estrogen in the body of the woman, the endometrium proliferates. So more than 3 mm in postmenopausal bleeding is significant, and 5 mm for those on HRT. So I told you in postmenopausal women, the patients can be on HRT. So if the patient is on HRT, the cutoff point is 5 mm. And if the patient is not on HRT, if the ET thickness is more than 3 mm, you have to investigate her. So in hyperplasia, there are different types, right? So previously, there is simple and complex hyperplasia. Simple hyperplasia, there is with atypia and without atypia. And in complex hyperplasia, again with atypia and without atypia. So in simple hyperplasia, without atypia, the percentage of the patient that can lead to cancer is only 1%. In a simple hyperplasia with atypia, the percentage of patients which can go into cancer, endometrial cancer, is about 3%. That is about simple. Now coming to complex, in complex hyperplasia, the percentage of patients that can go into carcinoma is about 9%. And without atypia, with atypia, 29% of the patients can go into carcinoma. So this is simple classification, simple and complex hyperplasia. Now it has changed. So now they have divided into simple hyperplasia, that is just endometrial hyperplasia, and endometrial intraepithelial hyperplasia. So like CIN, cervical intraepithelial hyperplasia, there is endometrial intraepithelial hyperplasia. So simple hyperplasia, that is without ATP, hyperplasia without ATP, and in endometrial intraepithelial hyperplasia, it is with ATP. Now the classification is like that. Okay, so this is the cause. So you have to. So how do you treat? So simple hyperplasia without atypia or complex hyperplasia without ATP, in both these conditions, what you have to treat with progesterone. So because with or without treatments, in simple hyperplasia, about 70% of the patient, 60 to 70% of the patient without treatment, they hyperplasia will regress. And if you treat with progesterones, about 80 to 90% of the patients will regress. Only 1% will go to carcinoma. In case of complex, also about 50 to 60% of patients, if you don't treat, also they regress. If you treat, about 90%, 90 to 95% of cases will regress. We treat with progesterone. Only about 3% of the patients will go into carcinomas. So that is a treatment for simple or complex hyperplasia without ATP. You give progesterones. So progesterone is nothing but you have to give a medroxyprogesterone acetate about 10 mg per day in the last 10 to 14 days of the cycle. Next is complex hyperplasia with simple and complex hyperplasia with atypia. So atypia means the glands are increased, the glands to stromal ratio is increased, the mitotic figures are increased. So there is atypical mitotic figures, then there is nuclear hyperplasia, the chromatin content is increased. That is the atypical features. So that is called atypia. So how do you manage these patients? Suppose, so in ATP also, simpler complex hyperplasia with ATP also, there are two categories. She can be, if she wants to retain uterus, and some patient doesn't want to retain uterus. So if the patient doesn't want to retain uterus, you can just go proceed with the simple hysterectomy. But if the patient want to retain an uterus, she's not willing to sacrifice a uterus, then what you want to do? So there is a treatment for that. Same thing, progesterones are the treatment. So first you start with a medroxyprogesterone acetate about 10 to 20 mg per day. Last 10 to 14 days of the cycle you give her. About 3 months you give the treatment to her. Then again you call the patient and again do a biopsy. Suppose if in the biopsy there is regression, there is no hyperplasia, you want to leave the patient like that? No, you should not leave the patient like that. Even if it is restored also, you have to continue the treatment for 1 year with the low dose. So previously you give 10 to 20 mg per day, no? Now you reduce only 5 mg per day last 10 days of the, so about 5 mg per day, okay? About 5 mg per day you have to give for about 1 year you have to give to the patient. So that is the treatment. If she has normal picture after 3 months of medroxyprogesterone acetate also, you continue the treatment for 1 year with a low dose, that is 5 mg per day. Suppose after 3 months, you have taken a biopsy, but there is no regression, the hyperplasia with ATP persists, then what you want to do? There is another option. You can start with high dose of progesterone, that is megestrol acetate. You can start about 200 mg per day. You can give the patient. Okay, last about 200 mg per day, about 10 to 14 days you can give in a month. Last 10 to 14 days of the month you can give, and then for 3 months you can give the treatment. Then you can again call the patient and you can do a biopsy. Okay, then if it is regression is there, you can again continue for 1 year. If there is no regression, proceed to hysterectomy. So this is the treatment plan for an endometrial hyperplasia. So endometrial hyperplasia is also common cause for post-menopausal bleeding. So you have to exclude all these. First point you have to keep in mind is an endometrial carcinoma. But other causes, if you know only, you can exclude. No. So first is senile endometritis, you have excluded. Then you come to endometrial hyperplasia. Simple endometrial hyperplasia, just by a biopsy you can diagnose it. Next is endometrial carcinoma. So endometrial carcinoma is the second most common gynecological cancer. So in India, in the genital tract malignancy, what is the first most common? Carcinoma cervix. Next comes what? Next is the ovary. Next comes the endometrial. Next comes the vagina and vulva. So this is the order where the carcinomas. Overall, if you take the cancers in women, first cancer will be breast. Next is the cervix. Next is the, okay, next is the ovary, next is the endometrium, next then last will be vagina, and order of the malignancies. So if the patient is having endometrial carcinoma, 90% of the patient will be having bleeding. So there are 4 stages that we will discuss when we're discussing endometrial carcinoma in detail. But now you have to know, you have to exclude endometrial carcinoma to keep in mind. So this is all the treatment of endometrial carcinoma. In detail, we'll deal when we are dealing with endometrial carcinoma, but you have to know the cause. So simply you have to know that here you can diagnose endometrial carcinoma by simple endometrial biopsy. So simple endometrial biopsy. And why it is important here is when you're talking to the patient in history, you have to know the risk factors of endometrial carcinoma. So what are the risk factors of endometrial carcinoma? If she's an nulliparous, if she's very obese, her BMI is very more, okay, morbidly obese women, and in history she's having early menarche and late menopause, and if the patient is on tamoxifen exposed. So when will the patient will be using tamoxifen? When she is having breast cancer, she will be using tamoxifen. Okay, all the risk factors should be kept in mind when taking the history of the patient. Okay. So this is the staging of endometrial carcinoma. Okay, now I'm not going to discuss all this because today our topic is post-menopausal bleeding. You have to exclude endometrial carcinoma, right? So history. So you have to, how to approach. So in history, you have to ask the patient, when was your last period? So you have to confirm whether she is menopause or not. And when did the bleeding start? What are the precipitating? There are any precipitating factors like trauma. Okay. And what is the nature of the bleeding? Like postcoital bleeding is most common in cases, cervical polyp and carcinoma cervix. So what is the quantity of the bleeding she was having? And I told you in the previous slide, you just see what are the risk factors, if she's having any risk factors. So where she's having diabetes or hypertension, high BMI. So all these are risk factors. So nulliparity, suppose if she's not having any children, she's risk factor of unopposed estrogen, right? And you have to see other any symptoms like pain, fever, changes in the bladder or bowel function. All these you have to ask. And associated personal family history of bleeding disorders. So there'll be family history of bleeding disorders, family history of cancers you have to ask, and whether she is on HRT or not, hormone replacement therapy you have to ask, and is she having any coital relations or any problems during coitus, and past obstetric history, past surgical history, and when was the last smear, that is pap smear was done. So this history you have to exclude. Then coming to your clinical examination. So first you have to examine the general and systemic examination. So obesity, BMI you will ask, can you see any thyroid, pallor is there, BP, blood pressure you have to see, weight loss, fever, everything you have to see, and you have to examine the breast of the patient. Okay. Next, careful examination of the abdominal and pelvic exam. So you can see the abdominal palpation, any masses you have to see. So any masses per abdomen is palpable, then you have to do a per vaginal examination. So per vaginal examination is a bimanual examination. So bimanual exam you have, so by bimanual examination, first before doing bimanual examination, you have to do a perspective examination. So first perspective examination, in the perspective examination, you can take a pap smear. So take a pap smear and then do a PV. Okay. And then you see any masses. You have to confirm your abdominal findings with the vaginal findings. So this is this perspective. So this is a perspective examination. You can see. So here, what is that? It is infection. So you can see the, what is this? Curdy white discharge all of the cervix. Okay, you can see the flakes. That is the whitish flakes are adherent to the vaginal wall. So what is a typical? It is infection candidiasis. Okay. So you have to, so the patient is complaining of bleeding, maybe you have to determine the bleeding site where, from the, it is from the cervix, or it is from the vagina, it is from the vulva, it is from the uterus, or it is from the bladder. So confirm the site of bleeding. That is very important. And when you're doing a perspective and PV, you have to see any foreign bodies, any lacerations, any cervical polyps, any senile atrophic vaginitis, ulceration from ring pace. So when the patient is having prolapse, when the patient has history of putting a pessary, then for a prolonged period there can be ulceration that can cause postmenopausal bleeding. And in senile atrophic vaginitis, I told you, because in a postmenopausal all the estrogen is decreased, she can have senile endometrial vaginitis. Here the patient will be very discomfort, there'll be soreness of the vagina. Okay, There'll be sometimes what happens is it is because of disformation of the cells, there'll be adherence of the vaginal wall in case of senile endometric vagina. The patient will be pain, she's having pain, and she also will be having dyspareunia. So all these are symptoms of senile entropic vaginitis. And you can, if any foreign body is there, any lacerations, any tumors, suspecting cervical tumors, vaginal tumors, vulval tumors, you can just exclude simply by your perspeculum and PV. Then you have to assess the size, counter, and tenderness of the uterus. Lastly, you have to also always a vaginal examination, local examination is completed when you finish rectal examination to exclude colorectal problems. And you can see many advanced stages of the carcinoma you can exclude by doing a rectal examination. So this is a cervical. So first speculum examination. This is the cusco speculum. This is a pap smear. Okay. So this is a taking of the pap smear with the. This is a pap smear, right? Spatula. This is liquid cytology. So this is a liquid cytology bridge which is needed to take the smear, liquid cytology. So this is a colposcopy examination. So colposcopy, this is instruments we are having in our OPD. So this is a colposcopic view. And what are the investigations you want to do? So everything you have to exclude. So first basic investigation is complete blood count, coagulation studies, LFT, RFT, the liver function test, renal function, chest X-ray. So this is, so these are the tests which LFT, RFT, and chest X-rays to in stages of carcinomas, advanced stages there, then you will do usually. Okay. So what are the specific investigations? This is important because now you want to exclude carcinoma of the endometrium, right? Mainly for postmenopausal bleeding, carcinoma of the cervix, carcinomas. So what you have to do is you have to do sampling, endometrial sampling. So sampling is different from a biopsy. So sampling is just you obtain a small bit of tissue from the uterus. You're suspecting to have any pathology, and then send it for histopathological examination. So there are different procedures. Outpatient is procedure. So that is, there is no admission of the patient. There is no admission. Just you can do a diagnostic technique that's simple to perform, does not require anesthesia, and is generally well tolerated by the patient. There are now many devices for performing endometrial biopsies in the outpatient setting. So you have Pipile sampling, you have vibroaspirator, you have a Novak curate. Okay, these are the things. So you can see. So this is the Novak curate. So this is a curate, okay, without anesthesia, because the thickness of this curate is very thin, about 3 mm. That is usually doesn't sometimes require dilatation also. Just you can go into the cervix and into the uterus, and just then you by twirling movements you just by twirling movements of the curate, the endometrial tissue is sucked in into this curate, and then you can aspirate, okay, by a syringe. So this is the technique you use. This is office endometrial biopsy. So you can see here, this is what, this is a Pipile curate. So a Pipile curate advantage is it is very flexible. It is made of polypurpurine, and depending upon the size of uterus, it conforms the size of the uterus. So there is usually less cramping to the patient, and also there is a plunger here, which if the plunger here is closed, it indirectly acts like a suction. So there is no need to connect the suction at the end. So when the plunger is closed, it indirectly acts by suction. Okay, so this is what, this is, there is a suction. So this is the aspirator, this is the vibroaspirator. Okay, so these are the instrument, hysteroscopy instruments. So dilatation and curettage remains a gold standard. So dilatation curate means you have to dilate the cervix to go into the uterus with the curate. So because dilatation is required, you should give anesthesia to the patient. So when you perform a dilatation curettage, anesthesia is required, and it should be considered when the endometrial biopsy is non-diagnosed and there is high suspicious of cancer. Usually when there is high suspicious of cancer, you have to do a dilatation curettage, and most important is fractional curettage. If you are highly suspicious of carcinomas, you should do fractional curettage. So fractional curettage is nothing but you have to first take an endocervical biopsy. Before putting a uterine sound, you have to take an endocervical biopsy, and then through sound you measure the uterus size, and then you introduce the dilator, then dilate, and then introduce your curate, sharp curate. then you have to take a biopsy from all the areas, so from fundus, from the anterior, posterior, lateral walls, and then you have to put in separate samples of bottles. Why? Because you can identify the site of malignancy, whether it's from fundus starting or anterior, posterior, lateral walls. You can know the site of malignancy. So, if you're suspicious of highly malignancy in this patient, you have to do a fractional curettage. If it requires anesthesia, you have to dilate and then you have to cure it. This is the procedure. So, normally, simple outpatient procedure is enough. Okay, so this is the thing. This is a curate. Okay, this is a sharp curate, right? Sharp curate. So what is the basis for your dilatation curettage? Your thickness of the endometrium, your endometrial thickness stripe. If it is more than 3 mm in case of postmenopausal women, you have to take an endometrial biopsy. If the patient is a HRT, then 5 mm is the cutoff point. Okay. So you can see this is a scan, transvaginal scan. So this this is the, see, this is uterus. This is the counter of, this is the fundus of the uterus, right? This is the fundus. So this is the endometrium. So you can see this from here to here is the endometrial thickness. So this is a trans showing a normal endometrium. So clearly you can differentiate endometrium. Here if you see, okay, transvaginal, what happens? You can see this, it is not, this is from here to here, endometrium is thickened and usually suggests of an endometrial cancer, right? So in postmenopausal bleeding, if the endometrium is less than 4, then you can just wait for 1 year, and if bleeding continues also, you take a biopsy and then you see whether it is secretory or proliferative endometrium. Normal findings are, if the patient is secretory or proliferative endometrium, you can just put on progesterones. Suppose if endometrium is greater than 4, okay, then you have to diffuse, when you take a biopsy, if there is diffuse thickened endometrium, in a scan, if there is diffuse thickened endometrium, you should do a biopsy. If it is a focal mass or thickening, or that is you're suspecting any polyp is there, then you do a hysteroscopy and just see where is the focal mass coming from. So depending upon the biopsy report, you have to treat. So MRI is very rare because it is a costly investigations we usually don't do, but if you're suspecting a cancer, for staging you do an MRI. Okay, CA125 markers usually when you're suspecting ovarian cancer you do. Okay, what is approach? So when management is, first you correct the general condition. When the patient is having any anemia, or patient is in shock, you correct the first the patient condition, and then you hospitalize her, you assess the blood loss, and then treat first. So you have to assess the blood loss. If she's very anemic, first restore her blood volume. Okay, if she's anemic, usually we give Paxils. Then you have to see what is the cause. So what is the underlying cause? Okay, so this is up. So this is the thing where when the patient comes with postmenopausal bleeding, this is how you approach it. So simply when the patient comes with a postmenopausal bleeding, you have to take a proper history. In history only you will know almost some of the conditions you are in your differential diagnosis. So you will come to a DD. Then after examination of your per abdominal examination, per vaginal examination, almost you will come to a diagnosis. So to confirm your diagnosis, the investigations. So how to approach? So main investigations here is your TVS scan, transvaginal scan, and your endometrial biopsy. So endometrial biopsy is different from endometrial sampling. So sampling is just a bit of tissue is taken in your OP procedure. So there is no anesthesia required. There is no, just half an hour before you give a painkiller to the patient, and then you can do an OP procedure. So in OP, you can just take an aspiration, a sampling. So there are different instruments you can take without dilating the cervix. What are those? Pipili curate, Novak curate, vibroaspirated, and Carmen cannula. So this is the 4 instruments you can do in an OP procedure. You can take an endometrial sampling. So what are the other cases you require endometrial biopsy? That is a fractional curettage. That is when you're suspecting in highly malignancy. You're suspicious of malignancy, then you have to go directly to take a biopsy. Biopsy is nothing but you should dilate the cervix. Then for dilating the cervix, you have to give anesthesia. So in outpatient procedures of sampling, there is no anesthesia, no? But what are the complications? What are the complications for doing an endometrial biopsy or a sampling? Is there can be overbleeding, you can perforate the uterus, there can be infections, all these are taken care of. So after doing the procedure, you have to put her on antibiotic therapy. Okay, you have to compulsory put her on antibiotic therapy to avoid infection. So depending on the treatment I told you, in atrophic vaginitis, if you diagnose, you can just simply treat by giving a estrogen, that is conjugated estrogen, that is Premarin, conjugate equine estrogen you can give orally or locally, you can give for atrophic vaginitis symptoms resolve. Okay, next, if you are suspecting endometrial hyperplasia, then you have to treat accordingly, whether it is a simple hyperplasia or complex without ATP or with ATP. So that is a treatment. Suppose if you are diagnosed endometrial cancers, then you have to treat accordingly depending on the stage. If you diagnose cervical cancer, you have to, depending upon the stage, you have to treat the patient, right? Then if the patient is having coagulation disorders, you have to treat accordingly. If she's having any tumors, so you have to exclude tumors, endometrial carcinoma or a fallopian tube or an ovarian tumor, treat according to the stage. So this is how you evaluate a patient of postmenopausal bleeding and you treat the patient. So this is a question for you. So whenever the question is given about postmenopausal bleeding, simply the definition of postmenopausal bleeding, start with the definition, then start with the causes. Here in postmenopausal, the causes are local causes and systemic causes. Then after causes, then what are the symptoms she can present. So different, depending on the causes, how the patient can be presented with. So symptoms and signs by your per-abdominal per-vaginal examination, how the patient will present. And then is the investigations. So investigations, routine investigation and the specific investigation. Specific investigation is your endometrial biopsy and endometrial sampling, MRI. All these are hysteroscopy guided biopsy. So all these are investigation. Then last is the treatment. So treatment depending on the cause. Simply you put under these headings, you'll be given good marks, right? Thank you for your patient listening. అయిపోయింది రాజేష్ అదొకసారి ఎండ్ ఎక్కడ కొట్టాలి ఓకే 4 కదా ముందే సిస్టర్ నన్ను చెప్పింది మామూలుగా స్ట్రిక్ట్